Good morning, everyone. Welcome to the session on COVID-19 and interventional cardiology. My name is Carlos Galvão Braga, and I work as an interventional cardiologist at Hospital de Braga in Portugal. First, we would like to thank Abbott for the sponsoring of this session. COVID-19 has changed the way we live, the way we treat patients, and we interact with each other. It is being a great challenge to tackle this pandemic and cardiovascular patients at the same time. It's a great privilege and honor to have with us such a group of distinguished participants of international and national renown. Let me introduce you the moderators of this session. Remotely, we have Professor Darius Dodek. Welcome, Professor. He is the actual president-elect of the APCI, the European Association of Percutaneous Cardiovascular Interventions, and works at the JU University Hospital in Krakow, Poland. We will have also remotely Professor Fausto Pinto. Welcome, Professor. He was one of past presidents of the European Society of Cardiology. He is the president-elect of the World Health Federation and the national coordinator of the Medical Schools Council. He works at the Santa Maria University Hospital in Lisbon. We'll also have three excellent speakers. We have two more moderators here in the room. Professor Manuel de Almeida, who is the head of the Interventional Cardiology Unit in Santa Cruz Hospital in Lisbon, and Dr. João Silveira, who is the president of APIC and works at Santo Antonio Hospital in Porto. We'll have three excellent speakers here in the studio. Professor Helder Pereira from Garcia de Horta Hospital in Almada. He was one of past presidents of APIC and currently is the regional champion of Stent Save a Life initiative in Europe. Remotely, we have Professor Giuseppe Tarantini. Welcome, Professor. He works at the University Hospital of Padua in Italy and is the president of GISI, the Italian Society of Interventional Cardiology. From La Paz University Hospital in Spain, Madrid, we have Dr. Raul Moreno. Welcome. He is also the president of the Spanish Association of Percutaneous Cardiovascular Interventions. We also have, as members of the panel of discussion, two prominent young interventional cardiologists. They will interact with us remotely with written questions. They are Dr. Miguel Borges dos Santos from Fernando Fonseca Hospital in Amadora and Dr. Ricardo Rodrigues from Funchal Nélio Mendonça Hospital. Now, without further delay, it's time to start the presentations. The discussion will take place at the end of the session. We encourage all the online viewers of this session to participate by sending to us their questions and comments at any time during the session. Please, Professor Fausto Pinto, would you like to make any comment before the presentations and then hand over to Professor Manuel de Almeida to present the first speaker, please? Professor Fausto Pinto.
Good morning, everybody. It's a pleasure to be here with all of you, and also to congratulate APIC for organizing this meeting, even in these difficult circumstances, but it's important that we keep on with our activities, and certainly this will be it's been a very important meeting, and this session particularly, it will be very important because it's addressing some of the issues that we are all facing in the setting of this pandemic, and this has been actually hitting not only the problem related with COVID itself, but the indirect cost of this pandemic, particularly in the cardiovascular setting, and I'm really much looking forward for the discussion, for the presentations of our colleagues also from other parts in Europe that have been facing the same challenges that we are all facing, and that certainly will be very exciting to discuss, to see, to exchange some experiences. We do need that because we are living now this second wave in Europe, and it's hitting everybody, and it seems that it's even harder than the first one. And certainly we need to learn from what we've done in the last few months, try not to make the same mistakes, and try to move forward in a way that we could do the best for our patients, for our communities, and basically for what we know what to do, but sometimes it's complicated, and it's good when we are all together. So thank you to the organization, thank you to the colleagues, and looking forward to our discussion for the next few minutes. And I hand over to Manuel Almeida, which I take the opportunity also to greet. Manuel.
Thank you, Professor Fausto Pinto. So I will get the pleasure to present Giuseppe Tarantino, a dear friend from Italy. Giuseppe, you have the word.
Thank you. Thank you for having me. It's a big pleasure to be part of this meeting. I will share my screen. Can you see it?
Yes, it's okay.
So my task is the new normal cath lab after COVID. Actually, this title seems to be a little bit, strange, because actually what we are facing is not a new normality, but a new pandemic. So I'll try to answer to the point. And I would like to start first from here. This is the updated and new definition from the WHO of the COVID-19 cases. This is very important to know because it's more extensive and a little bit more complicated. Because we have clinical criteria, that means acute fever and cough. And to this, that belongs to the previous definition. We have to add many other symptoms and signs. Among them, we have to remember the anorexia, the diarrhea, the anosmia, azusia, and many other things. I will show you that the weight of all these different symptoms and signs is hierarchical, completely different in this new definition. And then we have the definition of the acute distress respiratory syndrome that you will see as a very important, a very important role and weight in terms of the final definition of COVID-19. Then we have an epidemiological criteria that are almost copy and paste. That means working in an area with a high risk of transmission, residing, traveling area with community transmission. And actually what counts for us is the healthcare workers that by itself counts and can eliminate all the other epidemiologic criteria on our side in the hospital. Then the third pillar is, of course, the role of tests. So what has changed? So suspected cases are all the cases with clinical plus minus epidemiological aspects. But probable definition include clinical plus minus direct contact, but the presence of standing alone anosmia or azusia or positive chest imaging is sufficient to adjudicate the probable COVID-19 disease for a patient. And this is it's a completely different story compared to the previous definition. Obviously, the confirmation needs call for positive test. Having said that, turning out to the hospital, we can eliminate the vast majority of all these things because, at least in Italy, what we have to do and what we do is actually test for all patients, urgent, emergent, or elective case, and a periodic test of 2 weeks now, because the situation is going to be a little bit worse now in Italy, every 14 days for the healthcare personnel. So how do we face, let's say, between brackets, the new normal? So for emergency urgent case, we go for fast. And actually now we have used in Italy the antigenic, and especially in my university, antigenic test. That takes no more than 10 minutes to have the results. It seems that is almost super impossible in terms of result, not completely super impossible, but very close to the result of molecular testing. When the result is not available in the lab, you have to treat the case as a probable COVID. That means full PPE for the healthcare personnel. Then we have gray zone room, 1 or 3 hours. When you have molecular testing, you need at least 2 hours. So you have to wait. And in case of confirmed COVID, you have to move the patient to a dedicated COVID ICU. So this is very important because we have 3 parameters that we have to consider. This has been on the left-hand side, the situation in Italy, July 2020. As you can see, the COVID, the area under the curve in pink, the COVID-19 infection was fairly below the maximal ICU resources. So you can tackle emergent, semi-urgent, and elective case. We didn't have any problem. So there was a kind of restarting and also a makeup of the procedure, reducing the waiting list of the patient. But actually, what we are facing is not exactly like that, but there is something in between these 2 pictures. But on the right-hand side, you can see the situation of March. And I hope, as Pinto said, to not reface this situation. But at that time, the ICU resources were completely overwhelmed by the COVID-19 infection. In Italy, it means that we have to occupy 2,400 intensive care beds. At that point, we will have a new lockdown. So this is already set up as a perspective in the next, I hope, never, but few months, okay? So in this case, you have to decide to prioritize the case. So emergent case, for sure, you have to tackle and to do. You have to discuss about semi-urgent and elective case. So going to the urgents, we have the rules, some rules suggestion from the APIC, KEFO, Dudek, and many of us, Moreno, myself, and many other people is part of these documents. Just to highlight that in case of STEMI, primary PCI is still the gold standard, but when you foresee an extra delay of 1 hour because of COVID, you have to think at fibrinolysis. Quite consistent with the last release on non-STEMI guidelines is the recommendation for non-STEMI patients in the shadow of COVID. That means within 24 hours, but after test, you have to treat these patients just to, it's very important because you need to avoid to waste and to overwhelm the PPE resources. So having a test 10 minutes antigenic or 2 hours is very important. You don't have to rush unless you have a very unstable situation that claim for 2 hours, 2 hours intervention because you need to get earlier. Let's skip to elective case. So 3 main concepts, overarching principle. The first one is prioritize the patients, then to plan the procedure, and then to reduce the length of hospital stay. This is what we do in my university, and actually is going to be submitted in the APCI document part 2 that will tease about, how to restart selective activities and other things. It's a very nice document for me. So we have 2 different situations, emergent, semi-urgent, and elective. That's we name tier 1, 2, and 3. But actually, tier 1 is very simple. In Padua means Canadian Cardiovascular Classification 4, left main or last remaining vessel, or angiography diagnostic or PCI and decompensated ischemic heart failure, or stage PCI when there is a non-culprit lesion that is at least 90% in terms of narrowing. Then you have the type 2, that means that you can postpone but not too much. You have to do the things within 3 months. And actually here you have a dyspnea class 3, proximal LAD, diagnostic angiography for significant symptomatic left ventricular dysfunction. And the tier 3 means that you can postpone for more than 3 months when you have, mild to moderate symptoms. Related to the valvular heart disease, this is a very important issue also to deal with. And actually, when you have a near 4, you stay in a tier 1. whatever is mitral or aortic or aortic valve disease. For tier 2, that means within 3 months you have a near class 2 with left ventricular impairment, and this is both on the side of severe aortic stenosis or mitral regurgitation, and also for aortic regurgitation, tricuspid regurgitation, etc. We want to have a diagnostic catheterization when we have a clear symptoms that is near 3 or marked left ventricular impairment. For all the other situation, we can postpone the patient. The last one are other intervention. For this intervention, we do not apply in my institution a tier 1, never. We have a tier 2 for LA occlusion in patients that's absolutely need because of recent TIA or stroke and an enormous risk of bleeding. We need to do something for these patients, or other situation where you have a clear recurrence of major ischemic or thromboembolic events. So in summary, and this is the most critical part, I'm talking to Darius, to Fausto, to the moderator, to Joao, to my friend Joao, and to all the other people connected. The interplay between healthcare resources, the stage of pandemia, and the tier of our case, because it's not possible, it's impossible to standardize. Because also in Italy, we have 20 different regions with 20 different healthcare systems and ICU resources availability. So it's a matter of really, something that need to be managed locally according to, the situation of the pandemic and the healthcare resources. But for sure, when you have a high level of pandemic and a major constraint, you have to deal just with a tier number 1. So test for all for us, at least in Italy, there is some difficulties to put together all the different countries in Europe. But I think we need to understand that we are going to be completely invested again from the pandemic, so we cannot make any sale and any discount in that, at least in Italy, it is clear. And we need to test all elective patients before getting in the hospital. So whatever is the stage, for sure, the appropriate PPE is crucial, is of utmost importance to protect the people, because if you have an outbreak in terms of infection of entire division, it's very difficult to take care of patients. So in conclusion, my last 2 slides are the most important slide to share with all of you. First of all, this is the situation in Italy during the March 2020 compared to the 5 years, the same period before the outbreak. As you can see, the percentage of mortality has increased overall of at least 50%. Actually, I can guarantee to you, not a little half of this case, even less, belongs to the COVID. But this slide is still unpublished, but has been submitted. I think is very, very, very important. So in red, you have the mortality, overall mortality during the outbreak, March, April 2020 in Italy. In blue, you have the line of the mortality in the 5 years before. So there is a clear gap. But when you look at the green line is the mortality that has been sensed and attributed to COVID. That means that there is a clear gap between the bump, the red bump, and the green bump. That means that all these, at least 50% of the mortality belongs to cardiovascular, thromboembolic, cancer, and many other things, because these patients were not treated for 2 reasons. They refused to get hospitalized, or we didn't have the chance to cure this patient. So this is a very easy forecast for the future, because in Italy now we have less than 100 mortality cases attributed to COVID, but the overall mortality is increasing again. because the people has started again to have fear of COVID, of the shadow of COVID. And in perspective, even though if we don't have the overwhelming of ICU resources, probably we will see this bump in terms of non-COVID related mortality. So the management of the new phase is also related to this point, to the risk and the fear of patient to not be cured again, and to face a new increase in mortality, but not because of COVID, but because of the fear of COVID. Thank you for your attention.
Very much, José, for excellent presentation as usual. Now we are going to move to the next presenter, Raúl Moreno from Spain. You are going to give a talk, The Missing STEM, What Can you do differently in the next pandemic? Raúl.
Good morning, everyone. Thank you very much, dear friends. Thank you very much for the kind invitation to participate in this annual APIC meeting. It is a great honor for me to participate in this session. I am also very glad because of the excellent relationship we have among the Portuguese, Spanish, and Italian associations of interventional cardiology. So it's an honor for me. Respiratory infections increase the risk of cardiovascular events, and this occurs not only with pulmonary infections but also with upper respiratory tract infections. And simply because of that, we should have expected an increase in the number of patients with acute coronary syndromes in general and with STEMI in particular being attended in the hospitals and the cath labs during COVID pandemic. And also we know that infections induce platelet hyperreactivity. Immune response to infections may facilitate plaque rupture. In the case of COVID, the virus may produce endothelial cell infection and endothelitis, and also mononuclear myocardial infiltrations have been found in COVID patients. However, the number of patients coming to the hospitals with STEMI and coming to the cath labs depends on many different factors, depends on the hospitals, on the hospitalization beds, on the cath labs, physicians and protocols in each center, patients, social media, press media, ambulances, and all we know that during the pandemic, especially during the acute phase, there was a tremendous overload of the hospitals. There was a decrease on the availability of hospital beds, cath labs, ambulances. In many regions, physicians and protocols were more conservative, were more restrictive for invasive testing, and patients had fear to get the infection if they go into the hospital, and this was of course very conditioned by the social media and press media. The experience in Spain was very clear. During the first weeks of the pandemic, the Association of Interventional Cardiology of Spain evaluated using a survey what happened in 71 hospitals with cath lab with interventional cardiology in Spain, and we compared the number of patients being attended 1 week before the declaration of a state of alarm with 1 week after the declaration of a state of alarm. There was a very clear, very important decrease in the number of patients being attended in the cath labs. There was a 56 reduction in diagnostic procedures, 48 reduction in percutaneous coronary interventions, 81% reduction in structural procedures, and what is more important probably in terms of prognostic importance is the reduction we saw in the number of patients with STEMI being attended in the cath labs. This reduction was about 40%. The reason of this reduction is not a reduction in the availability of networks attending patients with STEMI, and in fact, also very soon, in Spain we published some recommendations related with the treatment of STEMI during pandemic, and the most important recommendation was to consider primary PCA as a treatment of choice in patients with STEMI. Now, this may be very obvious, but we have to remember that some groups, especially from China, recommended to recover thrombolytic therapy as an important option for treating STEMI patients during pandemic. And we think that the advantages of primary PCI over thrombolysis are even more important during pandemic because primary PCI reduces hospital stay in comparison with thrombolysis. And this is very important in a current situation in which sometimes the number of available hospital beds may be very important. And also primary PCI simplifies the management of STEMI, thus avoiding the need for non-invasive tests after the procedure, and this may reduce the spread of the virus. In our document, the use of thrombolysis was supported only in some patients initially attended in hospitals without cath lab facilities, especially when the delay in reperfusion was longer than 120 minutes was expected. This protocol has also been shown by my friend Giuseppe Tarantini, and the APIC also considered primary PCI as the treatment of choice of STEMI in patients being attended initially in centers with primary PCI facilities. Of course, this is the treatment of choice, and in cases presenting initially in hospitals without cath lab facility, and also in those being attended by the ambulances, the treatment of choice is referring the patient to a hospital with primary PCI facilities unless a longer than 60 minutes extra delay due to the COVID-19 pandemic is expected. We also gave some recommendations, for example, maintain STEMI networks in all the centers if possible, do the procedures as simple as possible, try not to stage procedures, so treat either the culprit only vessel or complete revascularization, but on one simple procedure, and perform contrast ventriculography during the procedure to avoid the need for an echo, thus reducing the exposure infection and shortening also the hospital stay. Then the reasons why the number of STEMI patients were reduced may be different reasons. Some reasons are related with the patients. The patients don't want to go to the hospital during pandemic because they have fear about the infection. Only when they feel very bad, decide to call. Of course, we cannot rule out a slightly decrease in the incidence of STEMI due to the less physical activity during pandemic. Also, there are some reasons related with the diagnosis and treatment of STEMI during pandemic. Diagnosis of patients with STEMI and with acute coronary syndromes in general may be more difficult, and they may lead to delay in the diagnosis and even to misdiagnosis in some patients. In some patients, acute coronary syndromes may coexist with COVID disease, and in these cases, diagnosis and mainly therapeutic strategies may be different. And also in some centers, protocols were more conservative during pandemic, sending less patients to the cath lab. And also in some centers, finally, a health system was overwhelmed, and a delayed response associated with ambulances, less hospital beds, less cath lab availabilities also could have a role. Because of all that, of course, many patients stayed at home. Other patients came to the hospital but were not referred to the cath lab because of misdiagnosis, delayed diagnosis, or conservative diagnosis. And in patients going to the cath lab during pandemic, we have seen I think in most of the hospitals some particularities. We saw complex patients, complex anatomies, sometimes with not clear indication for PCI because of the very delayed diagnosis, in which viability could be very important to take the decision of treating or not the patient. These patients sometimes have had a difficult medical management, needing prompt decisions sometimes. We have to consider that coronary artery bypass grafting is a bad alternative in this scenario, and sometimes the COVID infection cannot be ruled out coexisting with the acute coronary syndrome. Among the reasons explaining the reduction in the number of STEMI, it is clear that patients not seeking for medical assistance was a crucial factor. In Spain, we have, for example, data that showed that we didn't see any relationship between the STEMI drop and the COVID-19 incidence in different regions of Spain. And we saw an abrupt drop of STEMI patients just after the state of alarm. And we know that in Italy, for example, they have shown an important increase in sudden death during COVID-19 pandemic. The Association of Interventional Cardiology of Spain, after having published the initial survey, has performed a study in 75 hospitals to evaluate the influence of COVID-19 in pandemic in STEMI patients. What we did was to collect the data from patients with STEMI during the month of April 2019 and during the month that since the state of alarm declarations, so from the 15th of March to the 14th of April 2020. The number of patients was reduced in 23% comparing the month in 2019 and 2020. The number of patients, the proportion of patients presented by ambulance increased from 36 to 42%, and the proportion of patients with multi-vessel also significantly increased. We have seen an important increase in the use of beta blockers, an important increase on the use of thrombectomy devices, and probably this is related with more thrombotic lesions during pandemic. And what is much more important is that the mortality rate was increased in 47% because in 2019 was 5.1% and during pandemic raised to 7.5%. This slide represents the time intervals between symptoms onset and reperfusion. I think this is very interesting. The total time from symptoms onset to reperfusion increased in about 33 minutes. This was a significant increase. And what is very interesting, I think, is that this increase was explained by an increase in the interval from the symptoms onset to first medical contact. This time increased in 34 minutes. This is very important, I think, because this represents that the system, the STEMI networks worked perfectly during pandemic, and this illustrates the strength of our system because, for example, the interval between the first medical contact to the cath lab arrival did not change. In fact, it was reduced in about 2 minutes. So the title of the presentation was "What can we do differently in the next pandemic?" Unfortunately, we are not in the next pandemic, but we are still in this what we have called the second wave of this pandemic. And what we can do now is, I think, to insist on primary PCI as the treatment of choice, unless we have an unacceptable delay for sending the patient to a primary PCI center. I think it is very important to maintain all primary PCI centers, to increase the number of ICU and CCU beds in the hospitals. Primary PCI teams are not replaceable, so I think it is very important to try to protect the teams, rotate if possible, to protect the patients from the infection, the healthcare workers from the infection. It is crucial, I think, to convince the society, to convince the patients not to seek medical assistance if they have chest pain. I think we have to make the hospital a safe place to be in. We have to show this to the population, and I think it is very important to perform public campaigns trying to convince the patients having chest pain, especially if they have any cardiovascular risk factor, to attend to the hospitals. Of course, this has been also shown by Giuseppe Tarantini. It is crucial, the protection for the patients and healthcare workers. It is important to maintain clear circuits to do PCR test in all patients, in that case, in STEMI patients, rapid test if possible, in order to have the patient diagnosed when we finish the procedure. For healthcare workers, the rules or recommendations about the personal protection equipment, masks, etc., are of course obvious. Provide medical mask for all STEMI patients, and if COVID-19 is suspected or confirmed, try to do the procedure in the negative pressure room if possible. Limit the personnel in the cath lab to essential personnel, and of course maintain all the recommendations we have in the APIC and in all scientific societies recommended. The protection is very important for the healthcare workers. In Spain, for example, I think it is the country in the world with a higher number of healthcare workers with infection. It is very important to maintain the protection, not only for our own safety, but also to maintain our work team, and also to protect our people, to protect the patients, our family, and the society in general. I think we are in a very bad situation, but I am going to show what our great star, Rafa Nadal, showed, that this crisis has overwhelmed us, but we are a great country. So thank you very much.
Raul, thank you for this excellent and comprehensive talk. I certainly retained some of your advices. And we'll move on to Dr. Elder Pereira, that will show us how to get back on track.
Good morning, Mr. Chairman. Good morning, Raul, Tarantino, Kudek, and Fausto. I have nothing to declare concerning this presentation. And as happened in Italy, you have people dying of COVID-19, but also more than 5,000 unexplained deaths now. And when I was invited for this talk, how to get back on the track, I thought it was to look how to return to the normal before COVID-19. I'm going a little bit back 12 years ago, looking for the path that we did to arrive here. And I'm sorry, I'm going to talk a little bit of Stand for Life, because we have here some data that I think it's important to know. And then I'm going to compare Portugal with the other European countries, just 1 or 2 couple of years before the COVID crisis. So 12 years ago, you were one country with a few prime PCI procedures in comparison with the north of Europe countries. And not because of logistic reasons, we had enough cath labs. Our main cities were connected with good highways, and you don't have important cities more than 2 hours from a prime PCI center. It was more an organizational problem. It's why we integrated the Stand for Life initiative in 2011, and we found 3 main barriers for good performance on prime PCI. Patients not calling 112, a long patient delay, ambulance system not taking the patient directly to prime PCI centers, and some hospitals without the 24/7 and a long system delay. And for monitoring this initiative, we started these surveys, 1 month survey each year, we call Moments, and this year we repeat the survey. I'll show it later, the Moment COVID-19. And of course, we started, I'm not going into detail of this, public campaign, television, newspapers, radio, and also educational and organizational programs for personal health system. And the result were these: the patients that call to increase from 23 to 47%. But the patient delay from the beginning was very high, almost 2 hours, and didn't change during the 5 years, the following 5 years, and also the system delay more than 2 hours. The reason for this, I'm not going to discuss here. This doesn't mean that the Stent for Life or the initiative was a failure. There are other reasons for this. But if we look for private PCI hospitals, the patients that call 112, the mean time for door to balloon was 50 minutes. And if the patient going directly to an hospital with prime PCI, not without prime PCI, the mean was more than 100 minutes. And also, the patients that call 112 were within the time for recommended by the guidelines. And also, the number of prime PCIs per million increased in 1 decade, tripled, and now you are performing more than 400 per million. So, a couple of years before the COVID crisis, what are the challenges that Portugal faces in order to overcome the problems that we have now? One question is if you have economic and financial money to allow the convergence with the more developed countries. Another question is if you have human resources to respond to this challenge. And finally, to what extent did the COVID-19 crisis jeopardize this convergence effort? We know that in Europe, the main cause of death, of premature death, is ischemic heart disease. And Portugal, if you look for our gross national income, you are in the middle of the graph. But if you look for more developed countries, you are not in the middle. And the percentage of GDP that we expend in healthcare is about 9.5%. And it's not so different from the other European countries. Here, the problem is that 9 or 10% of our GDP is completely different for 9 or 10% of Switzerland, for example. And there is something good. The prevalence of ischemic heart disease in the Mediterranean countries is lower than in the north of Europe, but not so good because the premature mortality before 70 years is higher in Portugal than in our neighbors. And if you look for the human resources, here you are in cardiologists, you are in the middle of the graph. But in intervention cardiologists, no. You have less than 10 interventional cardiologists per million, and it's lower than the other European countries. And these are the results. You are performing less angiograms per million than the majority of European countries. You are performing less PCIs and less primary PCI. And here we are in the eye of the hurricane. Now you are with about 3,000 cases, 3,000 a day. And the question is, which is the impact of this in the system it was before, as I showed. This is not only a Portuguese problem or European problem, it's a global problem. Recently, we performed this survey in the countries participating in the Save a Life initiative, and almost all the countries decrease the admissions with acute coronary syndromes, as a Tarantini rule showed in Spain and in Italy. And also the STEMI patients decreased the admissions, and the performance of primary PCI the same. Looking to Portugal for the COVID moment, so March and April 2020 in comparison with 2019, we decreased the primary PCI in 17%. The patients calling 112 didn't decrease, even they increase. But look at this, the patient delay and the system delay was already very high, and now is higher. The patient delay 120 mean, and the system delay 151 minutes, almost 3 hours for the system delay. I would like to show you the waiting list for the interventional cardiology, but you don't have these figures. What we know, this is Visão this week, and the cover title is Victims Beyond COVID, and you have here official numbers. There was a decrease of consultations, appointments, hospital care, diagnostic, etc. And not having numbers of the country, I have numbers of my hospital. And the waiting list for interventional cardiologist for coronarography more than 100 patients, for CTOs PCI 23 patients, not because you don't have cath labs or doctors, because now you don't have nurses and you don't have beds. And if you look at surgery, our patients are waiting 300 days to be operated, and 50 of them are waiting more than 1 year for surgery, and the worst, 5% died in the waiting list. And for EP and pacing, the same, and this. Even with these numbers, we had a reduction of reference to electrophysiology, more than 90% of the patients. So these patients are not being diagnosed. They are, I don't know where, but they are outside the system. And you are near closing the elective activity, and of course this is going worse, even worse. So, how to get back on the track? Of course, in Portugal we have strengths. We have a national health service that is universal. We have a network of STEMI or 20 that cover all the country. We have a very good registry of interventional cardiology. I think it's a good tool to compare and to know where you are and benchmark centers, etc. But you have weakness. We have fewer intervention cardiologists and PCIs and prime PCIs that are below the European average, and we don't have an official list for waiting for the official data of waiting list. And very important, I didn't address this problem, but it's a problem. There is a regional inequity in access for the health system. It's completely different to have a heart problem here in Lisbon or in Odmir or Castelo Branco. Completely different. But we have opportunities. Now, the health is at the center of our lives. And I think that the COVID-19 crisis showed that the weakness of the National Health Service, and it's a unique opportunity for the government and the entities to finance and reorganize the health system. We have threats. The economic difficulties are aggravated by COVID-19. And today, 24th October, the COVID-19 is a stress test for the National Health Service. So, in conclusion, before the health crisis, Portugal was still facing some difficulties in management of acute coronary syndromes. COVID aggravated the previous difficulties and overwhelming stress of the system, leading to great difficulties for patients in having access to interventional cardiologists. But the COVID-19 highlights the social importance of the health system. This increase the visibility could be an opportunity for the decision makers to invest in the health care system. Thank you.
Thank you very much, Elder, for your excellent presentation. Now I'm going to give the word for Carlos to continue the session.
Thank you, Dr. João Silveira. As we were expecting, we had 3 amazing presentations. Congratulations to the speakers. I think your talks were very clear and pragmatic. Now we can kick off the session. We have many topics to discuss. I think the best way to do this is by starting with the comments of the moderators and then move on to the questions posed by the audience and the panel of discussion. I just want to make a brief comment and a question to Professor Darius Dudek. Most of the European countries are now in the second wave of COVID-19. We have learned a lot during the first wave. We know better how to deal with the virus and the behavior of COVID-19. What do you think, Professor Darius Dudek, that we should do now in the second wave to treat better cardiovascular patients?
Thank you very much for this very interesting symposium today in the morning. When I was listening to all presentations, so all of them are consistent and they are according to, I would say, the new consensus which we are preparing in EAPCI, and I hope it will be shortly available for all people in 1-2 months. But what I am thinking today is a little different after all your presentation and after our last board of the European Society of Cardiology. I'm saying about the whole cardiology. That if you look for different countries and the different perspective, I think that interventional cardiology and cardiology is at huge risk now in Europe, because many governments will be confronted against the economic crisis. And some prognosis, they are saying that it will impact the medical treatment. One line could be that the government will keep the money which were dedicated to medical. Hard to believe that they will increase the money dedicated to medical services, but it's rather expected that it will be less money for medical treatment. And when the interventional cardiologists, like you are presenting today, they want to reduce the number of cases, even elective, I think it would be the proof for all governments that you can easily decrease the money dedicated to treatment with cardiovascular disease. I am not sure if it is a good strategy. So that's why my perspective, if you want to hear, I'm a little scared when I hear from different countries, as you presented today, that you are working alone how to reduce the number of procedures for interventional cardiology. I understand that the shortage of the intensive care bed unit is the only real limitation for me, because you will prove that you can decrease the number of procedures, you can observe increased mortality in your societies, and the governments will follow your recommendation and they will decrease the reimbursement system for cardiology. That's my perspective after today morning session and after last few discussions during the board of the European Society of Cardiology.
Thank you, Professor Darius Dudek.
If I may, I think this is a very important point that Darius just raised, and I think this is actually the role that the medical community as a whole and particularly the scientific societies can have here. And of course, the European Society of Cardiology as a global society, but also the national societies, because what we really have to show, and particularly learning from the first phase, is that there is a strong need to have absolutely support for continuing to treat these patients, because actually, and we've learned that, the main issue here, and I agree totally with Darius, the main problem or the limitation that we may face is eventually the need of ICU beds. But we have seen, for instance, in this second wave, and I would like also to know a little bit about some of the other colleagues, but for instance, in this second wave, actually we have a lot of cases, but proportionally we have less admissions to the hospital, and my hospital, we are admitting patients since the beginning for COVID, but the number of patients in the hospital admitted and also the patients in the ICU is actually, the proportion is less than in the first wave, although it's increasing now, but it's still less than the first wave. And the other thing, it's very, very important that we have a clear plan, and you actually showed, all the speakers showed that, a clear plan to make sure that the patients with cardiovascular disease, they have kind of a pathway that will have in the hospital sort of a pathway for cardiovascular patients, not only the acute patients, because those it's obvious, but also for the other patients that they may not be acute today, but they will be acute in a few days or a few weeks. So I think it's very important to make the case that if we don't treat these patients, if we disregard these patients and we're just doing emergencies and we don't do as close as normal to the cardiovascular patients, and we have that duty to show that, and that's where we can use our strength as because we have data. We have now data from all over the world. You know, the data that it showed from Spain, from Italy, from Portugal, we have now from all over the world showing the impact that this had in cardiovascular mortality and global mortality. It just came out actually every week we're having these reports coming from all over the world showing that. So we have to make this very clear to the politicians. Of course, we have to face and to make all that is possible to reduction, but we cannot make cardiovascular disease as a neglected disease. And we have to make these strong statements to the politicians, to the authorities, to ensure that this is a very clear message. And this is our role as a cardiovascular community.
Thank you, Professor Fausto Pinto. Now we are facing a crisis, a double crisis, an economic one and healthcare with COVID-19. What's your position about this, Professor Giuseppe Tarantini? And I would like also to hear from Raul Moreno.
I've heard, all the comments from Faust and Dudek, but what I think is probably is a little bit late, because we had 4 months to restructure everything. At least I'm talking about Italy, and now we are facing the same level of infections of January and February. So the point is that even though now we push the envelope, probably it's a little bit late. And the reality is that if we have an overwhelming increase of severe disease, not infection, but the severe disease, what is reassuring in Italy is that we have less than 100 deaths per day throughout the countries. And this is reassuring because we did not stop anything so far. But the point is, if we have a remarkable increase in the severity of the disease, as we faced, the last year, and the only difference is the average age of the patient infected, because during the main difference in Italy is that during the very early phase last year of pandemic, the hospital were not prepared. So there was an infection in vulnerable people with an average age of 70 to 75 years old. Now, actually, the mean age of the infected people is 50 years old. That means that the vast majority of infection belong to the community source. It's not anymore the hospital. So the hospital did an important job to separate COVID versus non-COVID patients, etc. So now what we can say to the people is that the hospital are place of cure, are not anymore place of infection. And this is a very important point. This is a very important difference compared to the past. But what we are doing now in Italy is to make 2 different paths and to say which are the hospital, as Pinto said, are performing the vast majority of elective cases. For instance, in Veneto, northeast of Italy, are the super hub university hospital. In this case, we have decided with the politician to divert all the COVID patients in peripheral hospital that has a very low number of cardiovascular cases, and to keep, the huge hospital and the central super hub tertiary hospital free from COVID. In this way, we won't stop the elective cases. So you need to have some pragmatic program to go ahead and to face the second outbreak. This is what we are doing. That is very pragmatic, and so far we are quite, reassured that we can, try to compensate the increase of infected case. On the contrary, the past year in Padua, we were overwhelmed because the University of Padua and other very big hospitals were COVID hospitals also. So we cannot manage also elective cases. So this was the main difference compared to what we are doing now.
Thank you, Professor. Raul Moreno, would you like to add a comment?
Yeah, I agree with all my colleagues. What it's clear, I think, is that we are living a parallel pandemic with non-COVID patients that is affecting to all type of patients. But I think the most important diseases are of oncology and cardiovascular diseases. So here, cardiologists have an important role now, trying to convince the politicians and the health administration that cardiovascular diseases are now a priority for them. And other thing is related with the elderly. During the first wave of pandemic, many of us thought that if there were many patients that were over 80-year-old dying from the COVID disease, we thought that it was going to be very difficult to perform again procedures, for example, TAVI in very elderly patients, because we had suffered other problem with these patients. But I think, at least in Spain, there were, from the social point of view, there were some people that thought that elderly patients were abandoned, but because they were not going to be admitted in the ICU because of being elderly. And surprisingly, now we have no problems treating these patients. So maybe the sensibility of the society has increased to these people. What I think, what I am seeing in my hospital is, surprisingly, in this second wave, we are not seeing a reduction in the number of patients with STEMI. Maybe the social campaigns we have done may have worked. What we are seeing now is an important reduction in the number of structural procedures. In interventional cardiology, I think we all the procedures are important, but especially those that save lives. And procedures saving lives are, of course, mainly those performed in acute coronary syndromes and also TAVI. But I think that the outpatient clinic is suffering a lot now. And this is now reflecting on our activity. We have less and less patients coming from the outpatient clinic, for example, for TAVI or for other structural procedures. So maybe, I don't know, but maybe that in this second wave, the patients that are suffering the most are not STEMI patients or acute coronary syndrome patients, but patients that need a structural procedure, mainly TAVI patients, but also some patients with needing mitral clip or other procedures.
Thank you, Raul. I totally agree with you. I hand over to Professor Manuel de Almeida. What do you think about this postponing of elective procedures? Now we are in a second wave and we will keep postponing the elective procedures like TAVI or coronary ones.
I think probably the second wave will be a little different from the first one. Although we have more cases, it seems that it's less severe. We are less mortality, and at least we get some learnings from the first wave. We are a little bit more prepared. We know what we expect. At least in my cath lab, we are not postponing procedures, and we are working normally, increasing the security, but we are not postponing. But I have to raise a question, is that we, in the cath labs, will have a last wave. It means in the aftermath of the pandemic, we'll have economic crisis and probably budget restraints. And most of the investment in healthcare was on ICUs, in ICUs equipment. It was not on PCI equipment, it was not on cath labs. I get a brief overview in the Portuguese budgets that are on discussion, and there is no investment, significant investments in heavy equipment for healthcare. Most in infrastructures like streets, roads, trains, and everything else, but not in the healthcare. So I got the suspicions that after the pandemic, in the last wave, we'll have budget restraints in our cath labs like we had in 2008 and 2011. And we need to prepare for this kind of backlash in order to, if possible, put a little bit more pressure in healthcare authorities to get some investment now in cath labs.
Okay, thank you. I think it will be somewhat difficult, but we have to try to do that. I have here so many questions from the discussion panel. I will start with one of Miguel Borges dos Santos to Professor Tarantini. What are you doing about NSTEMI treatment? Are you treating and doing CAT on weekends to shorten the hospital stay? Or are you doing as usual?
I missed the question, so I didn't understand.
Sorry,
Which patient are you talking about?
With NSTEMI patients, non-ST elevation myocardial infarction. Are you doing CATs on weekends or not?
We are on call. We follow the guidelines. So we used to do the cath lab, the diagnostic, the invasive angiography within 24 hours. And because one of the goals of the patient in a COVID situation is the early discharge. So you cannot keep the patients hospitalized for 3 days, 2 days, 3 days before having an angiography, and then to keep the patient there for other 2 days, because you need a very quick turnover of the beds. So this is our policy. Within 24 hours, also on Saturday, you have to do invasive angiography and treatment, and then the day after, you will send the patient home with the goal of complete revascularization for non-STEMI patients.
Okay, thank you. And now a question from Ricardo Rodrigues to Dr. Raul Moreno. Do you think that interventional teams taking care of STEMI patients should be regularly tested for COVID-19 in pandemic areas, even if asymptomatic? If yes, what would be the best interval tests?
Well, I think this is a very difficult question. I think it's not needed. I think the personnel attending STEMI patients are no different from all the healthcare workers. Because all of us are in contact with the patients. In fact, maybe even that clinical cardiologists or clinical physicians have a more direct contact with the patients. I think this question could be thought generally in all the healthcare workers in general, but I think it's in Spain, for example, we are not doing it. We're not doing it. Of course, we are doing tests if we have direct contact with any COVID patient, etc., as in the general population. I don't know what are doing other countries, but in our country we are not doing it.
Maybe I will add a comment from this perspective that in Poland we have the clear proof that the transmission is going from community. When it was July, August, and September, so in Poland, it was almost 0 infections, and the whole nation was convinced that we'll have not COVID at all again. And the numbers in March, April also were very low. When the people started to go to schools in the September, in the second part, and students in the early weeks of October, we have the enormous impact of a number of cases of COVID. When we have the patients and physicians, and especially the interventional cardiologists, and nowadays, if they have the COVID infections, so 99% for me, they are transmitted from home, from kids, from schools. Fortunately, tonight, the government has decided again to close all schools since Monday. So I confirm that nowadays hospital looks as a safe place. So the primary PCI physicians are not usually infected, I would say, in hospital or during the intervention from patients, but rather in Poland, we have the problem that the transmission are going from community and from homes, especially from kids which were attending schools. So that's why we have a completely different source of the problem now.
Thank you, Professor.
Can I step in the discussion?
We are running out of time. Just a quick comment, please. Professor Giuseppe Tarantini.
Okay, I agree. It's exactly what we said before. The community is the main source. But actually, we have to keep in mind also that out of the COVID-19 mortality, at least in our country, this is the heterogeneity among countries in Europe, about 10% were healthcare personnels. So the point is that I think this percentage is 5% now, probably even less, but the problem is not zero. So that is also my point.
Okay, thank you. Last question for Professor Elder Pereira. Do you have any data on how many STEMI patients called 112 had indeed a pre-hospital ECG before reaching the hospital? Was this worse during COVID-19 or the same?
I don't have the numbers, but I don't have here. But the patients, it increased the number, the patients that call 112, probably because the public awareness for COVID, calling the line 24, increase also the awareness about the STEMI, and the percentage of patients that contact the system by calling the line 24 and 112 increase. It's the only good item that increased.
Improvement.
Yes.
Comparing before the pandemic. So we have run out of time and we should close this session. I have to address a big thank to all the speakers, all the moderators, the panel of discussion, and every single viewer of this session. It has been a pleasure to be here and discuss with you the challenge faced by the interventional cardiology community during this pandemic. And I sincerely hope that in the next year or in the next years, we'll be all here physically in the APIC. Thank you all and enjoy the rest of EAPIC 2020.